UBC Learning Circle, hosted by the Center for Excellence in Indigenous Health. We are very pleased today to welcome Dr. Jeff Redding to the Circle to talk to us about heart health and some determinants of health, just kind of a comprehensive conversation. So before we begin, I would like to acknowledge that we are on the traditional, ancestral, unceded, and occupied territories of the Hunkaminam-speaking Musqueam people. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle. So to everyone participating today, the topics and conversations we have can sometimes be sensitive or emotionally triggering. If that's you for today, please make sure you're looking into some self-care. Feel free to talk to a friend, elder, counselor, family member, whatever you need for the day. Make sure that you do so. So introductions. My name is Cole. I'm from the Chowthil First Nation. I'll be facilitating the session today. Other Learning Circle team members in the room but off camera are Cynthia, our production coordinator. If you are on Zoom and you feel so inclined, please feel free to introduce yourselves in the chat box. And on to our esteemed guest. Dr. Jeff Redding is a professor at the Faculty of Health Sciences and the First Nations Health Authority Chair in Heart Health and Wellness at St. Paul's Hospital. As well, Dr. Redding is the director of the iHeart Center, Indigenous Health Education Access Research Training. Professor Jeff Redding has more than 2 decades of experience enhancing knowledge in Indigenous health issues both in Canada and globally. He obtained his Bachelor of Physical Education from the University of Alberta, before going on to earn his Master of Science and Doctor of Philosophy in Community Health Sciences at the University of Toronto. Additionally, Dr. Redding was the founding director of the Center for Aboriginal Health Research at the University of Victoria in British Columbia. He served as the inaugural scientific director of the Institute of Aboriginal People's Health at the Canadian Institutes of Health Research from 2000 to 2008. Jeff has also held the first endowed research chair at the Department of Public Health Sciences at the University of Toronto and played a pivotal role in the introduction of Canadian ethics guidelines for Aboriginal health research. From August 2012 to July 2013, he joined the Baker IDI Heart and Diabetes Institute based in Alice Springs and Melbourne, Australia, to lead the institute in the emerging field of global Indigenous health. In 2015, Jeff led the, I might mess up the name here, Wakabines Bryce Institute for Indigenous Health, based at the Dalai Lama School of Public Health at the University of Toronto, as the inaugural interim director. In 2016, Jeff was appointed as the inaugural British Columbia First Nations Health Authority Chair in Heart Health and Wellness at St. Paul's Hospital, based at SFU. Among his numerous distinctions, Dr. Redding received the C.P. Shaw Alumni Award of Excellence in Public Health from the Public Health Alumni Association of the Dalai Lama School of Public Health, University of Toronto in 2015. He also received the National Aboriginal Achievement Award from the National Aboriginal Achievement Foundation Canada, now known as INSPIRE, in 2008. And Jeff was honored to be elected an inaugural Fellow of the Canadian Academy of Health Sciences in 2005. In 2002, Dr. Redding delivered the prestigious 4th Annual Amyot Lecture at Health Canada, Global Indigenous Health Research, an Opportunity for Canadian Leadership. Jeff's broad interest in research and public health has brought attention to issues including, but not limited to, the social determinants of health, environmental issues including provision of safe potable water, health promotion and disease prevention, heart health, diabetes, tobacco misuse, and accessibility to health care among Aboriginal Canadians. So that was a really long introduction.
Oh my goodness.
And to say the least, I'm really excited to have you here, Dr. Redding. I'm going to turn the microphone over to you, so to speak.
Well, thank you, Cole, and Cynthia, who's this is my first opportunity to do a completely virtual talk, so I guess we're in the brave new world of digital technology and Indigenous health. I'm really grateful to be here. I'm Mohawk from Tyendinaga First Nation, which is located on the north shore of Lake Ontario. I was actually born in St. John's, Newfoundland, which is a bit unusual. I think Newfoundlander Mohawks, I guess, both have a history in not being afraid of heights and working in New York City skyscrapers. Although, anyway, I grew up in the city of Toronto, and I'm really grateful to be a visitor on Coast Salish territory, in particular today on the acknowledging the traditional territory of the Musqueam First Nation. Welcome everybody. I normally have people in front of me and I can see, but I get a sense that there's some 35 to 40 people online here. So I hope this is useful to you and really encourage questions. So I'll go through kind of a 20 or 30 minute presentation that talks about essentially tries to contextualize Indigenous health in a sense with how research is connected to improving the health and well-being of people. And because, sometimes research is seen as an end in itself, curiosity-driven questions, like in heart health and in research in general, Indigenous health, I wouldn't say that we're not interested in fundamental questions, but for the most part, we direct efforts on applied type of research questions that are connected to improving health and well-being. And when we do research, we try to make sure that we don't that we take very seriously the time commitment people make to make space for research, and we try to base it on community engagement. So I'll talk a little bit about the ethics in the background, and I guess my research chair has, I'll talk a little bit about that as we go through and explain with some of the slides. But anyway, I'm very grateful to be here today. The first slide here, I wanted to show St. Paul's Hospital, and for some of you who may not be in Vancouver, sorry, should I be announcing that? And in Vancouver, and so the hospital was built in the 1930s, and according to the reports for the architects and engineers, if there was a major earthquake in Vancouver in the near future, probably less than 10% of that building would be standing. And that means that an asset like the hospital could be a liability in the case of major disaster, like an earthquake. And that has major implications because the asset of not only the hospital itself and the equipment, but the personnel, you would rely more heavily on a hospital in the case of a disaster. But, there's a long history in the city of Vancouver with First Nations and other Indigenous populations, right up to the present day using the hospital. And so I have a picture there on the slide of the sort of architect's rendering of the new hospital that's going to be done. And I think it's something that we all need to turn our attention to, is that in the next 100 years or so, that will be the place of healing, for this region. And not just Vancouver, but this is what we call a tertiary care hospital. So people will have access to that from the north, from rural and remote communities. So it's an opportunity to think about, how healthcare services could be integrated to meet the needs of a growing population of First Nations and Métis, and there are Inuit people living here as well in the city of Vancouver, and to make that place culturally safe and accessible. That's something that I think we all need to turn our attention to, because it has implications for future generations. So the first hospital is a faith-based hospital by the Grey Nuns, a Catholic order, I believe. And, around the 1930s, just show the next slide. This is a picture from Albert Bay. And of course, that was like a lot of the residential schools were in, full implementation mode. And this is on the, North Bay, Albert Bay. And, there were many schools in British Columbia, and a lot of the horrendous circumstances led to disparities in health that we are currently trying to address today. And I mean, residential schools were, and this is not a secret anymore, it's widely acknowledged that it was assimilation policy, forced genocide. But, if they had functioned and people had been, as they were intended by the Parliament of Canada and the body politic, if you will, to assimilate Indigenous people, then I guess it wouldn't be an issue, but it is an issue because Indigenous people are resilient, despite all of the things that the government threw at Indigenous people in terms of forced integration and assimilation. We're still here and we're still thriving and actually getting bigger and growing. And so the idea is to wrap our heads around reclaiming the incredible health and well-being that once was part of our cultures and has been interrupted by colonial factors that have really sought to create circumstances of unhealthy living and limited choices by shifting that traditional way of life to a sort of a colonial environment where we actually ended up didn't have the resources that we had once before. So I'll go into that, and I think most people know about this. It also includes the Indian hospitals, and the picture that I showed earlier, the St. Paul's Hospital. There were also lots of atrocities that occurred within the Indian hospitals' experiences that are being documented. So it's hard to kind of just erase those memories. I think so. We have some challenges when it comes to providing health services, especially in an area like chronic conditions where you don't get a quick fix. It's a condition that gets diagnosed, and then you need ongoing therapy and procedures and long-term commitment by health professionals, but also individuals. So we're talking reconciliation these days, and reconciliation in health and research. And I wanted to just underline this comment made by the former president of the Indigenous Physicians Association in Canada when they met at the Canadian Medical Association meeting here in Vancouver in 2016. He said, when reconciliation is talked about, we often talk about shared history. We talk about sharing recommendations and stories of the Commission, and those are all very powerful things. But when you look at what reconciliation is, it's the changing of two different groups, often on opposite sides, to become something better. It's not just about empowerment of First Nations and First Nations patients. It's about empowerment of you. And of course, he's speaking to the membership of physicians who are attending this meeting, to be better allies and to find your place in the Canadian fabric that doesn't exclude Indigenous peoples. So the notion here is that it's about relationship building. It's about trying to overcome some of the extremely destructive policies of the past and imagine a new future, one that's built on reconciling that horrible past and trying to turn it into kind of a Canadian fabric where everybody has this sort of equal opportunity for health and well-being to optimize the development. And I'll talk about how we get there or one of the ways that we can get there. And I want to emphasize too that this is by no means the last word on this. There's so much that we need to know, and we need to start doing research in our communities around traditional knowledge so that we can really find out a lot more about how we can reclaim that knowledge of the ancestors. And so let's go, and maybe we'll get some questions later on and some discussion. I did my training at the University of Toronto Hospital. So that was in the nuclear cardiology department, and
we're looking at a young Dr. Reddy.
Yeah, that was me back. I'm the guy, and that was probably 35 years ago. And so this was a healthy subject who was having his heart function and his oxygen transport simultaneously, evaluated during an exercise test. And you're exercising the body to see how it works under stress, right? And how the heart functions. So, I was doing Indigenous health kind of on the side with the health careers program at the University of Toronto back in the 80s. And I was pursuing research, and I liked science and research, and I still like it. And I'm really happy to be at the end of my career now in a heart health chair, because it is an area that I was very passionate about in my early career. I spent the last 20 or 25 years doing all kinds of things related to Indigenous health. But one of the reasons I made the transition to this area was because I was being trained in the School of Public Health, and just like this school here, and I was reading research reports about First Nations, Inuit, and Métis peoples, and as a scientist I was trained to evaluate something we call p-values, like statistically significant differences in groups. And And usually a 1 out of 20 chance to be, is considered beyond probability. It's sort of a statistically. And when we looked at Indigenous health, when I was reading about it, it was completely off the chart. I mean, there was, when you were looking at 5 to 6-fold differences in prevalence and incidence of things like diabetes and heart disease, it's, as a scientist, it's like, you don't believe it. Number one, it's like, this can't be happening because it's just so far off. And if it is happening, as a scientist, you're trained to do the research and you expect the system is going to respond to something that you reveal through the research. And so it was a bit of a shock to see that there were these huge variances in health and well-being for Indigenous people compared to the mainstream, and it didn't seem like anybody was doing anything about it. And being First Nations myself, I thought, well, I think I'm going to turn my attention to this area because I think we can have, or at least me personally, I could have a bigger impact doing work in this area for people who obviously are not being evaluated, and programs are not being designed to improve their health when it seems like we know a lot about this area already.
Dr. Redding, I actually have a quick question here. I've always been kind of curious. When we talk about prevalence rates, where do those numbers come from? Are those from individuals that go to the clinic themselves? Yeah,
there's a number of ways to establish prevalence. As you know, the difference is incidence and prevalence. Incidence is the number of new cases that in a population, and prevalence is the number of existing cases in the pool. And so the prevalence and incidence are usually evaluated by self-reports. So if it's self-reports, often people don't know that they have a diagnosis, say of diabetes or another condition. So that would underestimate the prevalence, the true prevalence. Some studies have gone into communities and they've literally taken blood samples of everyone in that community to establish whether anyone had diabetes. And when they do that, and they have done it in Quebec, they usually estimate the true prevalence or the number of existing cases is underestimated by about 20%. So if you have a population that has a self-reported 30% prevalence, it's probably closer to 40 or 50% prevalence. So, so there's different ways to establish prevalence, but the gold standard, you need a biological marker to establish, say, prevalence of diabetes. Heart disease is a little different because, the biological markers aren't as easy to evaluate, and they're like the test that I'm showing up here. That involves injecting a nuclear isotope into the bloodstream that gets removed through the urine, but you're imaging the heart directly, and you're imaging the oxygen transport capacity, the ability to exercise. And that, that's not a procedure that you could implement on a population-wide basis to establish the true prevalence of heart disease. So anyway, we'll get a little bit more into that because there's various forms of heart disease too that we could also look at.
Great, thank you.
But generally speaking, it's physicians and nurses and other health professionals can establish a diagnosis of a cardiovascular condition or a stroke or another chronic condition like diabetes. One of the things, and that's a great question because it involves working with other populations, other experts, other health professionals. So when the First Nations Health Authority came up with the idea of having a chair in heart health and wellness, they went out and got partnership resources from Providence Health, Simon Fraser University, and the Heart and Stroke Foundation. That heart with this slash there is the logo for heart and stroke. And so so that's good from a kind of a funding point of view, but looking beyond the funding side of that, it's also good from an expertise point of view. You can look at those right there. You've got a healthcare organization, including hospitals, nurses, doctors, equipment, and potentially a new one that's being built in the city of Vancouver. But and it's a very large organization. You've got the university, you've got for training and capacity building and research, and then you've got the Heart and Stroke Foundation has a long history of looking at health promotion, health prevention, education, and research. And then you've got the Health Authority, which is unique in the world in terms of First Nations peoples delivering healthcare services for First Nations peoples. And that's kind of a... So when you think of it that way, you're really kind of looking at these spheres of activity. And those are little circles. I'm not very good as an artist, obviously, but those are meant to be like spheres of activities around discovery, which is like research, treatment and care, which is medical care and access to services in a culturally safe environment, and then advocacy is looking at maybe charities like Heart and Stroke and other aspects of the work that we do within the Health Authority that look at advocating for patients' needs. And for example, looking at telemedicine, access to care, emergency access to care in rural and remote communities is a big issue, because when you're having a heart attack, you need to get access to care right away to save your life.
Yeah.
And also to reduce the impact of these conditions. So you have those three spheres, but you have the intersecting of the spheres around discovery and advocacy, treatment and research, and you can see that one actually helps to supports another one. There's a link between advocacy, treatment, and discovery at those intersection points. And so if you start working with other groups of people who are interested around a reconciliation type of agenda, you can think, you can work with experts in emergency care. You can work with experts in tobacco control. You can work with experts in training the next generation of public health scholars. And we're doing all those things in funded projects right now that FNHA is a collaborator and full partner on. So for example, there is, this is just a quick graph about, just to show that the health research funding, it's about $30 million a year across the country that gets funded through the Canadian Institutes of Health Research. So it's really important that we have and it should say Indigenous Health Research. This is a bit of an old slide. You see it goes up to 2010. But this is all to say that there's salary awards, there's strategic research funding opportunities, there's open grants, and there is a peer review committee at CIHR that evaluates research grants, and it has, because there's strong ethics guidelines that we'll be talking about, it basically integrates community engagement with research excellence to make sure that it's the best research possible, and it's also translated into policies and actions that improve the health of Indigenous people. So I think research is emerging as an independent kind of health determinant, and we'll talk a little bit about that too. So here's an example of what we're doing at, in addition to my research chair, I guess one of the outcomes of the chair with the First Nations Health Authority on heart health and well-being is this center at Providence Health Research Institute, and it's funded by the Providence Health Foundation, in part along with Heart and Stroke Foundation and, as I mentioned, SFU and FNHA. And so IHEART stands for Indigenous Health, Education, Access, Research, and Training. So while the focus is heart, it actually goes beyond that into a number of areas. For example, if you're looking at education and health, you can see that it says life course interventions, health determinants, cardiovascular partnerships. If you go down to research, you're looking at, as I mentioned, rural, remote, isolated care. So it's really about trying to think about doing research in a very practical way. And one way of explaining it is you could have a research center where I could be the director. I could get a research grant and I could do that project with, people I might hire for that project. And that would have an impact. But something like this could have a much bigger impact because it actually engages a bunch of partners. It creates a platform for research that works around these organizations, and it integrates the work of organizations into a plan for doing research that says, okay, you're a non-native person, you're the expert in emergency care. And as a matter of fact, Dr. Jim Christensen here at UBC, we're working with the UBC Faculty of Medicine to look at a project on emergency care, and we're collaborating with the New Challenge Tribal Council, Tackle Lake in northern BC. But that's just one example. So we have this project and we work with them, we create this research environment that is mutual respect. Everybody's learning about what each other does, and then in partnership they go forward to do research together. If you could take something like that and multiply it by 100 or 200 projects where it becomes the culture. It's a piece of what we do here at this university or at the hospital or within the... So in a sense, it's like embodying reconciliation into health and well-being and using research as the tool to make that happen. So I put this up as an example of what we're doing. And actually, there's Rebecca Lee is a manager who works at Providence Health Research, and it's basically just the two of us in this iHeart Center being a catalyst to get other existing groups. And we have other projects, people who are sort of engaged. It depends on where the person's at. If they have strong community partnerships and relationships already, then they're kind of going on their own. Dr. Pat Camp is a person at Providence who works in the area of respiratory illness and rehabilitation. She's working with Northern Tribal authorities, First Nations, to look at COPD, chronic obstructive pulmonary disease. In any event, that's an example. So
sorry, Dr. Redding, if I may. So iHeart really works at connecting all of these different organizations and the research projects and everything else together, kind of almost bringing them into a circle that we can all then move forward in together, right?
Exactly.
Really embodying traditional methods and ways of knowing.
Very much so. And I mean, if you look at the training part of there, I'm involved with Nadine Caron, Charlotte Lopi, Margot Greenwood in a 4 university kind of collaboration, which we call the Mentorship Network, which is, it's more than just those universities. It goes out to a whole bunch of other organizations. But the academic leaders are 4 Indigenous scholars, and including the Indigenous Center of Excellence here at UBC. And then that's evolving itself in something called the Network Environment for Indigenous Health Research. And that's going to fund the next generations of scholars working with communities to turn their attention to finding solutions to, health-related issues and problems that need research to move forward. And sometimes research is proving what we already know kind of thing, but it does turn attention to issues that may not be receiving the kind of attention. Yeah. We know that there's issues in emergency room care and the access that people receive, particularly rural, remote. So turning attention from people who are the sort of experts in this area has a lot of positive, spin-offs for communities. When you're having a heart attack and you're in the middle of a northern community and the snow is blowing or the rain is coming down, you really need to have a team behind you to optimize your health and well-being, your chances of survival, and minimize your chances of having a serious negative consequence. So you can see there that there's lots of different ways to look at interactions, and so we like to think of it as a catalyst and as a model for how other regions in this country can start to think about creating a network where we don't look at Indigenous health as a silo or sort of as a department that somebody takes care of, but everybody kind of works around it because it's just the way we do things, in this country. That's the goal, anyway. Right. So here's a good example. Back in 2000, I'm one of the people in this picture, this was the original founding group of scientific directors, president and CEO of the Canadian Institutes of Health Research. And so in that picture, you had 13 scientific directors and vice presidents and the CEO. And each of those scientific directors, you could think of them as, disease and body part institutes. You could have a heart and lung disease body part kind of institute. And that was there, and we had good collaborations. What this showed me was that over the period of 8 years when I was there, I was able to develop relationships, professional relationships that resulted in sharing resources and knowledge and expertise among these institute directors that we use to kind of facilitate research that happens. Now, Carrie Barassa is the current scientific director at CHR, and we were just in a meeting in Ottawa with her about reconciliation, actually. But I'm in the back row, and the person standing next to me is Morris Baer. And Morris Baer is he's a retired professor from UBC, this department right here, and he was the scientific director for the Institute of Health Services and Policy Research. So, that shows it's been 20 years since that picture was taken, and there's been a lot of changes. There's been a workforce created in health research. There's a lot of scholars, there's a lot of clinician scientists that are now working in that space. And so, one of the things that we really had to think about when we were doing research, there was this very negative history of research that was prevalent, not just in Canada, all around the world. For Indigenous people, they felt that they had been researched to death. They had felt that that research was meeting the needs of the academics who were engaged in research, and it wasn't improving the health and live circumstance, the well-being of the Indigenous populations who were the objects of that research. Yeah. And so a lot of research was, communities had said they had enough. And that was, so we decided as one of our early things, focus of our activities, strategies was to look at guidelines in ethics for research. And so what we ended up doing was within the Canadian Institutes of Health Research, these are 3 of the same covers in First Nations, Métis, and Inuit. We commissioned artists, and you can see that the syllabics are there in the Inuit version of it, which is sort of a northern alphabet based on sounds. In any event, it was providing ethical guidelines for the conduct of research with Indigenous peoples. And so it was the first time that we had this really set of explicit conditions that research would take place. And it's not meant to be the ultimate, but it was the minimum standard of research in communities. The first step, exactly. Because it was coming from the CHR, which is an agency of the Government of Canada, funded by Health Canada, if someone was in violation of those research ethics, the funds could be frozen, and there could be a review of so there was a bit of a policing that could be implemented, which was the first time that ever happened. Now those guidelines at CHR don't exist anymore because they were rolled into what's known as the Tri-Council Policy Statement for Research, Ethical Conduct for Research Involving Humans. And, there was, within that document in 2010, there was a Chapter 9 that was specifically dedicated to First Nations, Inuit, and Métis peoples. And we could have a whole talk about the ethics of research, but it's very rich in terms of specific guidelines that you need to consider. And you can't really have hard and fast rules when it comes to research because every research situation is different. And so when ethics get reviewed, it gets reviewed by a committee, a research ethics board. They take each application and they decide whether it's meeting the conditions that are in a document like that. And if it's not, it needs to be adapted to make sure that it's in compliance with those conditions. So this is an example of how healthy policy, actually filters down into the conduct of research, which in turn filters down into better research evidence and better products and that would improve people's health. That's the thinking there anyway.
If I may, Dr. Bidding, so there's a council that sits and evaluates each kind of application to do research, let's say.
Yeah, like here at UBC would have one.
So who, particularly involving Indigenous peoples, or those research applications that would involve Indigenous populations, who sits on that council to decide that interpretation?
Yeah, that's a very good question. Increasingly, historically, it was research scientists, in the areas of social sciences, health, humanities, physical sciences, engineering, the whole gambit. And I think there's been more of a consumer orientation brought to the research process. So each institution is different.
Right.
And, there are movements afoot, to have First Nations organizations do their own research review and evaluation. Like the First Nations Health Authority is working in partnership with academic institutions to move forward the idea that they could review their grants. The reality is ethics review provides third-party liability for the researchers too, because if there's untoward, unexpected outcomes that happen, which are negative and non-anticipated, you need to create a condition where it's absolutely safe for anyone to participate in research, and that the research itself is completely voluntary, that a person can leave the research project at any given time during the conduct of the research. Those are all fundamental issues around informed consent and all that. And so it is a very big conversation, but the people who sit on the panel, I think there is growing, it's actually a lot of work too, though, let's face it, to have the time to read a 20, 30-page proposal and
Absolutely.
to provide comments on that. So it's not something where you can just say, oh, well, we need more Native people on the council or whatever. We need to actually give people some buyout from their jobs or whatever it is that they're doing if we want their perspectives. So we have health directors working in communities who are really busy people, and we ask them to come and provide review of a grant. Then they need to be compensated. I mean, that's
Absolutely.
a fundamental thing, because in a sense, everyone at the university who is an academic, or they have an incentive, it's part of their job, in other words, to participate in the review. So that's one of the issues that I think is important. But again, this is not an insurmountable problem, right? It's something, if we want to get that perspective, it's in the ethical guidelines, and we need to kind of make it happen.
Great, thank you.
Yeah, so here's an example of what we talk about, and I'm not saying that this is the only example. There are many different examples, but this comes from a Mott Elder from Atlantic Canada, and it's kind of it embraces plurality, in other words, different ways of knowing and seeing, and so this has sort of mainstream issues around equity, and then Indigenous values and understandings, and it seeks to kind of, take advantage of both of those perspectives. And he uses this metaphor of seeing out of two eyes, and trying to, and I think this is appropriate for some kinds of research. In some cases, research needs to be all 100% community driven. In other cases, there's only, there may be 20-30% of engagement, depending on the nature of the project. And again, these things should get negotiated by the people who are the participants of the research, what their capacities are, what their interests are, and all that kind of thing. But I just put this up here to show that there's different models out there for, co-advancement of knowledge that allows to. What it basically does, it boils down to having a dialogue on research between, scientists and clinicians who are interested in new knowledge, and research with communities who have a vested interest in understanding how we're going to move forward to improve the health of our community. So in the area of cardiovascular care and research, which is what the topic is we're talking about today, we have what we call quantitative and qualitative methods. Quantitative are usually described as numbers, survey numbers, statistics, a lot of, things that describe communities in ways that are based on either tests that were done or surveys that were done. And whereas qualitative tend to be more hearing stories and understanding, people's perspectives on their experiences. And so, you have qualitative and quantitative research, but it's actually good projects mix the two together.
That's what I was just going to say.
Yeah, you have, so for example, knowing that your community has a 20% diabetes rate isn't that helpful until you understand some of the reasons like driving that. It may be that access to food security may be an issue. It may be that physical activity and opportunities for sport and recreation are just not there. So those are the things that when you know that information and you implement programs, you can reduce the incidence and prevalence of diabetes. So here's a couple of examples here of what we call clinical guideline concordance. That's like saying, okay, you can get a diagnosis of diabetes or heart disease through a test in a hospital or in a nursing station, but to what extent are First Nations, Inuit, Métis people, are those guidelines being applied equally in that population as they are in mainstream population? So that's a really important, what we're talking about there are patient journeys. If a person is diagnosed, what is their trajectory? In other words, what is their path? What does it look like?
Right.
And so some people are very, get depressed about having a diagnosis, and they feel that their life is kind of over when it's not. And that whole framing of a disease process needs to be altered. It's not over. It's a question of thinking there are things, medications that I can take. There's different ways I can manage my own journey through being a survivor of heart disease and, diabetes and other chronic conditions. So that's an important way of thinking about it. Everybody is at risk of illness, and most people will experience illness in their lives. And the question is, how do we optimize our living with those conditions? Again, with research, we can look at what we call administrative data linkage. We link data together from health services, and we can look at patterns of access to care based on the burden of disease in a certain region or community, and whether that community is getting the kind of care. And we do that by looking at health records. And that's an example of research that's extremely important when we're looking at access to care through an equity lens, inappropriate timing of care. And I'll talk a little bit about an example of that. The third area there is called clinician-patient engagement and decision-making. And I wanted to put that up there is just to say that you can do all the research you want, but clinicians, in other words, healthcare providers and their patients need to negotiate and need to have conversations. So sometimes it's beyond qualitative and quantitative research. It's actually about the physician and the patient examining areas like frailty and cognitive ability and trying to determine if a course of care is appropriate to that individual based on their circumstances. And these are all very individual, and they wouldn't normally be captured in administrative data linkage or surveys because they're kind of limited in what they actually get. So there's different issues we always have to be aware of, that there's reasons why there may be inequitable, what seems like inequitable care, but it could be based on some of the other, like that says, pharmacological contraindications. This person may have other things going that's not captured in the file. Again, qualitative tools are really important. In the qualitative tools, we can assess the cultural context that's occurring. That's the social and economic context. We can look at underlying interactions with other things that could improve or make worse your condition. If you have concurrent lung disease and you're a smoker and then you end up with heart disease, that's an important thing to know. You can look at, how a person perceives their own disparities in life. Like a person could say they have a number of problems, they have mobility issues, they have this, and then you could ask them, how do you rate your health? And they could say, excellent. Because they feel like I'm still getting around, and and we see that all the time. And other people who have what might be considered relatively minor problems consider their health to be poor because they don't like to be limited in any way. So that whole thing about a person, I guess, healthcare providers listening to the patients and creating this, relationship, the relation between the healthcare provider and the client as not just a sort of a healthcare interaction, but something that's ongoing is really important in the area of diseases that don't go away, that you kind of have to figure out a way to live with.
Yeah.
And again, that ties into that multi-dimensional lived experience. So one way of looking at it, or making an example, is that we're not interested in the video or in the photograph. Like, I could sit here and ask you about your health. You could tell me about it, and that could be the end of it. We could walk away and go in separate directions. But what's really helpful is to have that relationship where all of a sudden you do tests with your physician or your nurse, and then you do them frequently every 6 months or every year, and something goes out of whack in terms of your function, then that's important to know and address right away. It's much more valuable than having that one photograph in time.
Yeah.
You can see where the pattern of changes in a person's function. So when we talk about cardiovascular study designs, and this includes, I'll talk a little bit about the cardiovascular system in the next slide, we talk about different kinds of research studies that I just broadly put into these categories. What are methods? Different methods of inquiry. We have different methods and tools, and there's so many of them when you start to think about the broad scope of research in health. And so those are some things that we continue to work on. We need to look at different methods and tools. We have observational studies where most of the research that's been done for Indigenous people or on Indigenous people or with Indigenous people have been observations. So the typical diabetes is 6 times higher for Native people versus non-Native people. So that's an observational study. And so, you think that would result in some kind of strategy to change that. And that was really what got me into research in the first place, because it pretty, it goes into the area of human rights and social justice, because when you see through an observational study that there's a huge disparity, then it stimulates people to want to do something about it.
Yeah.
It also, at the same time, ends up stigmatizing the community as being unhealthy, which a lot of communities have felt that that's been kind of negative in terms of their own aspirations for, promoting good health for the community. So what communities have said very clearly to the research community is that they're interested in interventional studies, meaning that studies that actually bring into the community a program of intervention that's aimed to improve health. So if they know that young people are their body mass is too heavy for their body size, then that's going to create obesity, that's going to predispose to diabetes. So the interventional study might be studying physical activity and food security, healthy nutrition, that would reduce obesity, that would reduce, so what we're talking about is this trajectory of health and well-being and timing and intervention at the appropriate time with respect to age and gender as we go through life, and I'll talk a little bit about that. So this is the cardiovascular system, and I think we're somewhat familiar with it. The picture there, it's, you have the heart and you have the blue and the red there, and the blue is, sort of less oxygen in that blood. It has about 60% oxygen, and it goes to the lungs to get more oxygen. It comes back to the heart, and that's red, and it goes to the rest of the body to provide energy so that the brain and all the organs and the skin and the muscles can all function. And so it's these two parallel circulations, if you will, that go on every day that we live. And if it stops, then that's when life stops. And it's actually, the way the heart works is that the heart is a muscle, and it requires oxygen too. And so those little arteries going off the main aorta, we call it, that provides oxygen to the heart itself. And that keeps the system moving. This is also what happens in utero, meaning that in the fetal circulation, where the infant prior to birth is completely dependent on the mother. The lungs are not functioning, and it's like a single circulation, and the oxygen and nutrients are provided from the placenta through the umbilical cord, to the heart, and the heart is pumping and beating away.
Yeah.
And at birth, there's a number of things that change within the heart that stimulate it to be a normal kind of functioning with the lungs working. And I mean, we all know that happens, but it's really important to think about that, because what happens, this whole system gets built inside women and during the first trimester of their pregnancy. And so optimizing your chances for a healthy baby are really important on your behaviors for women when they're pregnant. So avoiding smoking and alcohol and drugs is really important for the developing. And also there's different kinds of infections that can also influence this, that can create what we call congenital abnormalities in the heart function itself, which can be long term. So this is a study here from Australia, for example, in the Northern Territory, where a cardiologist is treating what are called congenital heart defects, like with those valves and the heart function itself, that are caused by what's called a streptococcus infection, which is it's a bacterial infection which is completely treatable.
Yeah.
And so, that is an example of a program that needs to be implemented. We have the knowledge, but it's just, for whatever reason, the social, environmental circumstances where these children who had no choice to be born into are susceptible to these conditions. So, there's a lot of opportunities to actually make a huge difference, and that's what I'm going to sort of talk about. So these kids end up getting, because their hearts have been infected by this bacterial virus, or the bacteria causes these growths they end up having to have surgeries to their hearts too, and that improves their function, but it could be prevented. And we're in a school public health, that's what we do, right?
Yeah.
When we turn our attention to those little arteries on the heart that supply the oxygen to the heart to keep the system going, atherosclerosis is the sort of narrowing of the heart arteries that causes a lack of blood flow to the heart muscle itself. And that is the definition of a heart attack, is when you actually don't get the oxygen needed to the heart muscle. And the that ECG there shows what it looks like. There's a sort of a phasing. The heart stops functioning normally, and you can see evidence of it on the EKG or ECG. And this is what it looks like under X-ray. So the heart, of course, is moving. This is just a static image. And this is what happens. You can see that coronary artery on the surface of the heart is blocked. And all the territory, if you will, of heart muscle is not receiving the oxygen that it needs via the blood. And so what happens here is you actually introduce a technology in the hospital that puts a little wire down through there and inserts a balloon and opens that to reestablish the oxygen delivery to the heart muscle, and that's called a coronary angioplasty. And that's so there's an example. This is kind of an older slide, but that technology is kind of amazing because they snake this little wire down through that narrow blockage. Then on the wire they put a balloon and what they call a stent here, which is kind of like a little bit of screening. And this shows dissolvable ones that actually. But anyway, that opens that blockage, reestablishes the flow, and the oxygen delivery is so that ST segment on your EKG goes back to normal, and it preserves literally that real estate, that myocardium, that heart muscle, and prevents a heart attack. So it's a great thing. So here's a study that was done in Alberta, looking at the likelihood of coronary angiography with patients who are having acute myocardial infarction or a heart attack. So these are patients that are having their coronary arteries are blocked. If they don't intervene, there's going to be a heart attack, and because of that lack of oxygen. So the access to the care is what they call the coronary angiography, where they could potentially introduce that balloon and reestablish the oxygen. So Lindsay Croshoe is a physician who's one of the co-investigators on that grant. He's a Cree physician at the University of Calgary Medical School. And so what they showed here in this study was there was seemed to be quite a difference in the access to the coronary care unit, like for First Nations people having coronary episodes, heart attacks. But when they broke it down, what they showed was if you get through the hospital door and you get access to the medical profession, then your treatment and care is the same as everybody else. But there's a lot of issues of getting to that door and getting through that door when you're having an acute episode. And so that does two things. One is saying, okay, there's an issue here of access to care, and then we need to delve more deeply into what that is. Now we know that some of that access to care has to do with transportation, some of it has to do with the kind of quality care that's being provided in rural and remote settings to quickly diagnose. Some of it has to do with weather, and I think some of it has to do with other sort of more sensitive issues around cultural safety, racism people experience when they enter a healthcare facility, and those are issues that we need to turn our attention to try and fix. So again, this is the kind of research that says here we have a technology that can intervene in the treatment of care of vulnerable patients, but is that being equally applied in a system that's publicly funded? Mm-hmm. So let's just turning our attention to more of the upstream factors, the things that we know about that influence health. And this is an old slide that talks about socioeconomic status, cultural factors, working conditions, social community networks, lifestyle behaviors, and then those hereditary factors. So we've known this for a long time, we've probably known it for hundreds of years, like thousands of years. Yeah. And this is that notion that's similar to the determinants. It has to do with what we're calling here the life course trajectory, the embodiment of human potential and well-being. So life starts, and this is a lovely picture of that pathway where you have the joy of youth, and then you go in and go through. Sadly, I think this is a bit of a sort of a fantasy for a lot of Indigenous people, because it gets disrupted with health problems in different places when it doesn't need to be disrupted. Yeah. And as I said, the social environmental conditions can sometimes lead to infections that could have been prevented. Access to care could lead to untreated disease when it could have been treated and could have been intervention. So, but it's important to look at it this way, because as you go from birth to adolescence, adulthood, old age, there are, at each of those stages, there's opportunities where a person could intervene in an age-specific, gender-specific, appropriate intervention that would help a person. And I mean, most parents try to do that with their kids, right? Mm-hmm. And a lot of people try to do that in their own personal health. But some people need a little bit of help with that, and also the conditions in communities sometimes don't make it possible to do these things that you might otherwise want to do, but don't have the resources to do. Yeah. So the idea here is to look at the life course with a goal of optimizing what we're calling this trajectory, this sort of pathway to optimize health. So you can imagine that if a person has a healthy pregnancy and doesn't drink alcohol or smoke tobacco or during pregnancy, that's going to optimize the health and well-being chances for that individual. And it doesn't mean that it's a guarantee. It just means that all things being equal, you've actually done the best that you could try to do to optimize that. But it's not just at that stage. It's all the way through life that a person needs to do that. So what really matters in this is this complex interaction of health determinants in the Indigenous or in Aboriginal context over the entire life course. And it doesn't matter what you're starting with. If a person has disease or has a problem, there's always room for improvement. There's always rooms to, for example, if a person has had a serious injury and is no longer able to use their legs or what have you, there are things that can be done in that physical environment to optimize that person's health and well-being and to optimize the health of the caregivers.
Yeah.
So you look at this as a sort of larger ecological, the individual is kind of situated in a context where there's upstream things that are going on in a person's life, like these dark blue boxes looking at access to health services, income, employment, education, literacy, social connections, social support. And then we used to think biology and genetic endowment were sort of things that you couldn't have much control over. Well, it turned out that's starting to change as well, because there's different kinds of research and clinical applications that are starting to interfere with some of the progression of diseases and the switching on of illnesses. So one of those examples is a project that actually Nadine Caron and Laura Arbour are leading with Wyeth Wasserman and Dean Rigger, who's also in this department here. Yeah. And there's a grad student, her name is Chinoa. Yeah, she's like doing her doctorate working with this group. So it's reducing health disparities for Indigenous children with rare genetic diseases by improving access to diagnostic tools and treatment. And the research showed that it was there was a lot of these illnesses that were never diagnosed, so people would just live with these conditions that could have been treated. Yeah. But in order to collect biological samples, it involves a fair amount of trust, right? Because you're identifying a person's genetic, blueprint, and it could be potentially used for other purposes other than. And there were some bad examples of how researchers had actually done that, sort of run very fast and loose with the ethical. So you can see those boxes there showing that the First Nations Health Authority, the Assembly of First Nations, the Inuit Tapiriitsat, and the Métis National Council are all partners in the governance of the research project. So that's an example. This is the first time that like a large-scale national study is being done to look at health disparity by looking at metabolic and different molecular and cellular level factors that could actually be assessed to improve health care.
Yeah, we're actually going to have the Silent Genomes project come on the Learning Circle pretty soon. April 11th. So.
Well, there you go. I'm giving them a little bit of advance notice.
There you go. We're plugging for me.
A plug, yeah. So this is a complex slide, and I kind of want to walk through it because it is kind of encapsulating a lot of the things. This is Dr. John Frank, who is one of those scientific directors at the CIHR in the area of public and population health. Okay. So what he's got here are the upstream forces, and we all know this in public health, and many people, this is pretty widespread, I think. We know either through research or just intuitively that political, social, economic, spiritual, environmental, those things are forces in our environment that determine our health. Right. And that's true of individuals, families, neighborhoods, communities, right up to nation states. And this has all been sort of shown in quantitative studies. On the other side, we have, so those are the forces that influence health. The other side are what happens when a person gets sick or has an accident. The healthcare system, where most of the resources are concentrated, it's there to kind of, mitigate those problems and try to make people better and address their, and so the shifting of resources from healthcare or leaving healthcare as it is and investing in those political, social, economic forces to avoid health and disease is core, first year public health, population health that we all understand. But I think the general population needs to know that, when we're looking at health through an equity lens, that it's important to know that investments are required to narrow this gap in health and well-being. And the investments can go outside of the healthcare system. In fact, education, opportunities for employment, better housing, better access to clean water. We know those are the things that will influence health. And it's not just, again, this is where we get back into reconciliation. If Canadians generally understand that that's needed to make a difference, then it'll be, we're in partnership as opposed to, we keep throwing money at these problems.
Right.
So looking at this intersection of biological endowment in that one circle, the physical and social environmental exposures that we can actually try to influence, and then the interaction of biological factors with social, tobacco smoking is a good example there. We have some communities in Canada have a very traditional view of tobacco for ceremony, but many communities use tobacco more than they should. It was never meant to be an addictive substance. It was meant to be engaged in ceremony. But whatever, it's creating major health problems for people in a variety of areas. And the thing is, when you look at biological endowment, some people have a predisposition to be affected by tobacco smoke when it causes lung cancer, and some people don't. But the fact is, it's like seatbelts. The chances of having that problem, either lung cancer or a head-on collision, it's better if everybody agrees that we're going to prevent this thing by either wearing seatbelts or not consuming tobacco products. And again, that's public health. But that's important for people to understand because, there's also other benefits by altering our physical and social environments and looking at healthy behaviors that we can influence. So, if we're talking about investing in healthy outcomes and better futures, I think it's really important to think at the beginning of life as a really strategic investment in terms of optimizing health and well-being. This is called the fetal origins hypothesis, and it was first articulated by a man called Dr. Baker as a Baker hypothesis, and it's about optimizing developmental opportunities for improving health and well-being. And the science basically says is that what happens in utero can predict diabetes and heart disease in middle age. Yeah, it's interesting. So this is some of the ideas that there's kind of a genetic inheritance theory as well, where what you do is passed on to the fetus as it's growing, during pregnancy. But within the fetus, there are actually reproductive cells that can be influenced through epigenetic inheritance to affect 3 generations. So the consequences of, and it even says here that it could potentially go to a 4th generation due to direct, exposures. So the consequences of doing unhealthy behaviors are more about your own personal health, particularly if you're in that stage of, and so it's important for people to realize that there's things that we can do that can avoid these things. Like, okay, smoking is really important, and a person sees this slide, it's going to be a powerful incentive, I think. So there are research projects that we're currently involved in with the New Charlotte Tribal Council and Simon Fraser and a whole group of researchers. And this was funded by CIHR institutes to look at healthy life trajectories And it's looking at focusing on the long-term changes in health and well-being that can be influenced by interventions at these stages, right from the health of women of, childbearing age to what happens during their pregnancy, and then to track their infants and children over time.
Mm-hmm.
So the projects were received funding to talk to communities about under what conditions would this be possible. So that the actual dollars from the research agency went directly to communities to administer. And so as researchers, we're working for communities to make these things happen. And it's looking at optimizing developmental trajectories, they focused on diabetes, heart disease, and mental wellness. And it's very strongly focused on a community-led, community-engaged process for the science. So I guess I wanted to kind of begin to wrap up, and just to say that what we have here is this beautiful sort of representation of the shaman's worldview. And this was Norval Morrisseau, who was an artist who was given some paints when he was actually incarcerated. And he ended up creating a whole school of art that had never existed before. It's called the Woodland School of Art. And he's passed away now, but there's an image at there's actually a person standing there. So that gives you a sense of the scale of that piece. And it's really showing this thriving and bountiful world where all these diverse elements are in perfect balance. And to me, that kind of gives a sense of what Indigenous worldviews and perspectives are like.
Right.
Like it's complex, it's integrated, and it's really beautiful. So I think that's something that I think we can all reflect on. I just want to, I don't know if this goes into a permanent record, but there's a couple of resources here. The first one on the left has to do with, I mentioned, Bob Evans, who is, a sort of professor here in economics and sort of legendary person at UBC, Morris Bear, and I can't see the third name on there, but that book here produced out of this school here at UBC was really one of the early documents that showed that to look at health and health determinants through this population lens was really important, and healthy public policy emerged from that. We built on that with a book that I wrote and just had, I think it's still available at UVic as a PDF file. If not, I can provide access to it. It was just trying to integrate some of the things I've talked about. And the third document there has to do with the National Collaborating Centre on Aboriginal Health, looking at why do Indigenous populations, how do we pursue health and well-being? And I would actually plug the National Collaborating Centre up at University of Northern BC. It's part of the Public Health Agency. Mm-hmm. They have all kinds of excellent resources that are really well done, peer-reviewed. And it's Dr. Marco Greenwood who basically runs that place and does an outstanding job. So
fantastic.
Yeah, so thank you very much for inviting me. And
great.
I hope that wasn't too much information. You guys are still awake.
No, yeah. I think that was really great. Thank you very much, Dr. Redding. I really appreciated your time. As always, for those of you that are online right now, we will make a repository of all the materials that Dr. Redding has referenced here, and we'll try and get access to that other document in case you're ever interested. You can find it on our website on this specific sessions page. So with that, I think we're just about down to time. So I'll do my outro here. Have a couple plugs for the Learning Circle. If you have any questions for Dr. Redding during that time, please feel free to pop it in the chat box, and we'll get to it at the end. I'm just going to talk a little bit about some upcoming events that we have. Next week we have Dr. Lung is coming from pharmacy here at UBC. They're going to talk to us about cannabis and kind of with the legalization of cannabis, kind of the necessary, or not necessary, but some of the implications of that and how that can affect your health. So we're going to talk through that with Dr. Lung. In addition to that, as I mentioned previously, we have the Silent Genomes Project coming on April 11th. And although it's not currently represented on our website, it will be soon. We have a session on healthy Indigenous masculinity that's coming up on April 4th, I believe. So we have lots of really great sessions up ahead in the next coming couple weeks. If you're interested in any of those, please feel free to register for them. I think looks like we might not have any questions yet. If you think of anything else, please feel free to email us. I'm sure we can pass some questions along to Dr. Redding, and he'd be happy to help you during that time. Okay, so with that, again, thank you very much, Dr. Redding. It was a really great time. I had a pleasure chatting with you today. I hope everyone got a lot out of this session. And yeah, so we will see you next time. Okay, bye-bye.
Bye.